Hi, everyone. We're going to be starting in a few minutes. We'll have a few more folks log on, and then we'll get the presentation started. Okay. We have 122 so far. Keep growing. All right. All right, good afternoon, everyone. Thank you for logging on and attending today's webinar. Today's topic is professional ethics and dementia care with Linda Axtell-Thompson, as our speaker. Okay. So you folks know the organizers of this training is Hawaii Public Health Institute. Stephanie Moyer is the Community Initiatives and Training Coordinator. She is currently out on maternity leave, and she will be joining us at our next training. I'm stepping in. My name is Makamai Namahoe. I am the Grants, Contracts, and Operations Assistant at Hi-Fi, and then we also have a steering committee of 14 members involved in the Hawaii Public Health Training Hui. Today's sponsors and partners of the Hui are, again, the Hawaii Public Health Training Hui, which is a collaborative that offers ongoing continuing education to all healthcare professionals and community members working in Hawaii to promote health, social welfare, and well-being. We also have the Western Region Public Health Training Center, which has partnered with the National Coordinating Center for Public Health Training, plus 9 other regional public health training centers and 40 local performance sites across the nation to form the Public Health Learning Network. The PHLN's goal is to support healthcare workforces, education and training needs, and elevate the field of public health. This project is supported by the Health Resources and Service Administration of the United States Department of Health and Human Services under UBE 6 HP 27880 and Affordable Care Act Public Health Training Centers. This information or content and conclusions are those of the author and should not be construed as the official position or policy of, nor should any endorsements be inferred by HRSA, Department of Health and Human Services, or the U.S. government. So today's continuing education credits that will be provided are for licensed social workers and licensed clinical social workers, certified substance abuse counselors, certified health education specialists, registered dietitians, registered dietetic nutritionists, and dietetic technicians registered, along with registered nurses, advanced practice registered nurses, and licensed practical nurses. Request for the continuing education credits. Again, please register and attend the webinar training. After the training, we will send you an evaluation feedback survey. It includes a link. It will be emailed to you. Certificates of completion will be sent 10 days prior to the training. After the training, I apologize. We have a system where we are different from Valyan, so our emails go out in waves. We have a limit of 50 emails, so we ask for you folks to be patient. Sometimes when the trainings have a high attendance rate, we have to send them out in waves because we just have so many to send out. The feedbacks are due by today following the training. Please complete them by Friday, May 24th. I apologize for the Monday error. For folks who are phoning in, please email myself or Stephanie Moyer or the Hui and let us know what your name and phone number that you used today. And folks who are missing certificates after 2 weeks following the training, please email myself and Stephanie and we will follow up with you folks. So today the link, as you see here, this is on for folks who are trying to obtain the nursing education credits. I will be submitting or sending to you folks in the chat the nursing information sheet. Again, this portal is password protected and the password is on that sheet. So folks who have any questions regarding how to get their nursing credits, it is all listed on the information sheet that will be sent through the chat. But if you folks did not see it in the chat, please shoot us an email following the training and we will get that onto, along to you. And again, the survey expires 2 weeks after the training, so please complete that as soon as possible. Again, the planners and presenters have no relevant financial relationships to disclose. Information for Zoom, as folks know, these are the instructions to log on to the webinar. This is the link for anyone who has not registered. Please click on this link or copy and paste this link onto a new Safari website or Google, and it will take you to the registration. Again, recordings will be posted on our YouTube channel, which is found on the Hawaii Public Health Training Hui channel, and along with our other trainings that we've had so far and moving forward. So folks, join us today is Linda Axtell-Thompson, who is an adjunct faculty in nonprofit administration at Chaminade University, healthcare administration at University of Hawaii West Oahu, and ethics and aging at University of Hawaii at Manoa. She is also principal of Axtell Consulting, which offers consulting and training in ethics and strategy. She has her doctorate of bioethics with an organization ethics emphasis from Loyola University in Chicago, along with her master's in bioethics from Medical College of Wisconsin, an MBA with an emphasis on nonprofit management from Yale School of Management, and her bachelor's in philosophy from the University of Hawaii at Manoa. Today's learning objectives are to examine what is meant by professional ethics for healthcare professionals, discuss guiding principles and examples of good ethical decision-making, and to review recommendations in dealing with dementia clients with professional ethics and sound decision-making outcomes. So we will get this started.
No. Thank you. And they can see me now. Mm-hmm. Okay. Hello, everybody. It's my privilege to be participating today. And I hope you get some good information out of this, this training that you can use in your work with people with dementia and their caregivers. This is what's showing right now? Mm-hmm. Okay. This first slide, I just want to share with you because it sets the stage for why we're talking about ethics and why we're talking about ethical decision-making in the particular context of dementia. This is from a book, The Moral Challenge of Alzheimer's Disease by Stephen Post. And he says, seldom does human experience require more courage than in living with the diagnosis and the gradual decline of irreversible progressive dementia. While the body of the person with dementia will often remain strong for a number of years, mental capacities as well as the accumulated competencies and memories of a lifetime painfully slip away. The person with dementia is eventually swept away while caregivers look back and feel forever changed by their experiences. Let me see. I'm missing a slide. Okay. Sorry, there was a missing slide. If you want to get a copy of this presentation from me directly, I'll have my email address at the end. I'd like to ask that people hold questions until the end. Maybe make a note of the slide number that you have a question about so we can go back to it. But there's a lot of information to cover and I want to make sure that we're able to cover it all. Also, if there are any follow-up questions later on, please feel free to email me. Anyway, this presentation is going to be in basically 4 chunks. The first one being what I always call Ethics 101, which is a background on ethics in general. Then I'll talk a little bit about professional ethics, what it is, where you can reach out to look for the professional codes of ethics for your particular specialty. Then talk about ethical decision making, give you a few models to look at, and then we'll get into the specifics of ethics in dementia care. What I would like you to take away from this is a very high level understanding of ethics in relation to dementia, along with some tools and techniques and some resources and ways to think about issues that you might face as you're working with people with dementia and their caregivers. So we start with what I call Ethics 101. And the reason I always like to present this information is because often people tend to think that ethics is just about don't lie, cheat, or steal, or just about avoid conflicts of interest, or is just about the 4 principles of ethics, bioethics that people tend to know about. But what I want is for people to understand that there's a much greater depth and nuance about ethics and how it's applied in making decisions, and that it should not be formulaic or a cookbook approach to how do you make these decisions. And often, even though particular issues within a particular realm of healthcare has been well settled, in ethical discussion, you still have to think very carefully about how do these rules and principles and techniques apply to the particular instances of a particular individual. So first of all, why do we want to worry about ethics? Well, you do want to stay right with the laws, regulations, and guidelines for your practice. You want to honor those professional and organizational codes of conduct, and you want to manage the risk of complaints and lawsuits. But on a much more personal level, I believe we all want to be able to live out in our lives our personal values, our professional values, and to be able to sleep well at night when we're faced with some of these sticky issues that have come up in our daily work. So what is ethics? It is basically the study of the standards of conduct, of moral judgment, and moral choices that we make. It's the standards that govern the conduct of ourselves as individuals or as professionals, and it helps us define what is meant by ethical in different situations. It's the discipline that deals with what is good versus bad and what is a moral duty or obligation. There are diverse approaches to ethics, and these are called normative, meaning things we should do, as opposed to descriptive, those things that we actually do. So they're telling us, or we're telling ourselves, how we ought to act. There are diverse theories that look from different perspectives at the same ethical situation, and they won't always give you the same answer or the same take on what it is that you need to be doing. So you need to look at things from sort of multiple perspectives and understand that you're looking for a balance of different views to try and come up with what you think is the best decision at this moment in time for this particular situation. Now, there's a couple of fundamental problems in identifying which ethical standards we should be following. One is, what do we base those ethical standards on, and how do we apply them to specific situations? And there are at least 5, I've added a 6th one here, different approaches to how do we define what are ethical standards. And we as individuals coming from different backgrounds may not always agree on which specific approach we want to use. But looking at these as a whole help us understand how people might be looking at the same situation from a different point of view. For example, if someone tends to have a utilitarian point of view towards what is good and what is bad, they're looking at what is the most good or the least harm, or the best balance of good over harm. And they're looking at the consequences. What will be the consequences of the decision? If someone has more of a rights perspective on ethics, they're saying that the inherent dignity of an individual is based on them simply being human, and that people must be treated as ends in themselves, must be valued and treated for themselves and not as a means to an end, not to justify the end in how you're treating them. If you have a justice perspective, the idea is treating everyone equally or treating everyone fairly based on some standard that you can defend and explain to others. If you believe in virtue ethics, you're looking to live your life and act and decide in a way that's going to somehow exhibit your best qualities as a human being. If I choose to do this, what kind of person does that mean I will be? If I do this, does this mean I'm being my best self? Common good, people look at the fact that we live together in a collective community is good in and of itself. And honoring those relationships in the community requires respect and compassion for all, especially those most vulnerable. And then people who have more of a duty point of view, they say doing right is to do the right thing, follow the right procedure, follow the standards. And that's actually independent of the consequences. So if you think about it, if one person has a duty perspective and someone else has a utilitarian perspective, they could be at odds, even though each of them is saying, I want to do the right thing. So this is where you come into some differences of opinion about what is right and what is good and what you need to work through in making decisions for yourself and certainly for other people. In the field of bioethics, a lot of this has been distilled down to these 4 principles: autonomy, which is the respect for people and for people making their own decisions; beneficence, which is you should do good; non-maleficence, which is you should do no harm. It's kind of the flip side of beneficence, but on the other hand, it kind of sets a lower bar. To do no harm is a little easier than to always do good. And then there's justice, the fair distribution of benefits and burdens of any decision that's made. This is a practical approach to ethical decision-making because it focuses on these 4 common principles that most people can agree are all good things. And this is important because in our pluralistic society with multiple people coming from different cultures, different perspectives, different moral backgrounds, you need to try and find some common ground that you can make collective decisions around. But if you think about it, these 4 principles also have some tension between them, because if you were to maximize one, you might be having to give up something else along the way. One example would be if you are focusing on justice, then being fair in your distribution of benefits and burdens, there's a possibility that you could be giving up something in the realm of beneficence because maybe somebody needs more than other people do. But if you're being absolutely fair about how you're distributing, you might be lowering the beneficence, the good that you do for people who need more than the average person. What I also like to do is to make clear that ethics is different from laws and morals and values. And I bring this up because these terms are often sort of thrown together in the same conversation. So we need to keep in mind that ethics is not the same as law. They're related, but they're not identical. And if you think about it, not everything that is legal is necessarily ethical, and not that everything that is ethical is necessarily legal. If you think, for example, of when slavery was an acceptable practice in society, whether it was here in the US or back in England or other European countries, in Rome and Greece, and even in biblical times, that was a common and accepted practice, and today is considered completely reprehensible. Also think about things like civil disobedience, when you're intentionally breaking a law in order to force societal and legal change. And also think about where somebody is skirting the margins of legality, just staying inside the line of what is legal in order to make profits or to gain political advantage. Yes, their actions are legal, but they're not necessarily ethical, and they're not the kind of person, for example, that I want to hang around with. Ethics versus morals. Ethics is the study of moral awareness, judgment, and conduct. Morals relate more to what's accepted by the society or the group that you are in. The group view of what's right and wrong is what relates to the morals, as well as the rules that govern those actions and the values that are behind those actions. Ethics versus values. Values are part of your own personal life, your own personal philosophy of life, your basic beliefs about what's good and true. And you have moral values, everyone does, along with, for example, aesthetic values, political values, economic values. Moral values are one type. So ethics and values are very similar, but are not the same. Then I always want to make a distinction between compliance and discernment, because ethics goes far beyond complying with rules and regulations. Yes, the baseline is don't lie, cheat, or steal, but ethics goes far beyond that, and it deals with much more complex and nuanced issues beyond simply not breaking the law. A compliance mindset is you're looking to conform to the rules or the standards or the policies, and you want to ensure that people are aware of and then comply with whatever the relevant rules are. With discernment, what you're really trying to do is dig below surface perception and be able to make nuanced judgments about what you ought to do, perhaps when the rules are not that clear, or the rules are contradictory, pulling you in 3 different directions, and you need to decide what is the best thing to do in this particular situation. Now, when it comes to actually acting in an ethical manner, there are things that need to be in place. One of them is moral awareness, which is being able to actually recognize that a situation is raising an ethical issue. And this can sometimes be a problem because sometimes things present themselves as business decisions or organizational decisions or something else. And you have to kind of pause and dig a little deeper to see that there's actually some sort of an ethical issue that you really want to be addressing. Another thing is moral decision-making, understanding how you can move through the decision-making process to identify the best action. Moral intent is being aware of the underlying values that are at play in thinking about, discussing, and making these decisions. And then moral action is, are you able to follow through on your decisions and actually perform some action that is going to move the ethical dilemma further forward, or are you going to be sort of stymied by fear or uncertainty, even though you have an idea of what the right thing to do is? And that often happens because there are a lot of complications to acting ethically. Ethical dilemmas such as truth versus loyalty. This is where you have conflicting values, not necessarily values versus lack of values or right versus wrong. it's not necessarily right versus wrong choice. It's more like a right versus right dilemma. What do you do? So for example, truth and loyalty, both are values that are held in high esteem, but if push comes to shove, are you going to go for truth or loyalty? And I use the personal example that for me, truth is always paramount, and that's gotten me in trouble sometimes because for other people, loyalty is paramount. And if I tell the truth and somehow hurt a loyalty, they think I've done something bad when I am living and acting according to what is my higher value. Another one is individual versus community, very typical in social issues, in health issues. Short-term versus long-term, that's very typical in how organizations have to think about decisions that they're making. Justice versus mercy. Again, do you do everything absolutely fair across the board with everybody, or do you make exceptions for certain people in the name of mercy because they need something extra? Rationalizations are things we tell ourselves when we perhaps know what the right thing to do is, but we're sort of uncomfortable doing it. So expected or standard practice. Well, everyone does this, you know, so I'll just go ahead and do it. But it's often an exaggeration. Materiality. Well, this is not really that important. It's not really going to hurt anyone. So I'll just go along with the program, even though I know it makes me a little uncomfortable. Locus of responsibility is I'm just doing my job. And often you use that, or people use that when they're uncomfortable, and so they're shifting consequences and shifting the responsibility onto something else. And then locus of loyalty is, well, I know this isn't quite fair to the client or the customer, but I don't want to hurt my organization or my team. So these are ways we rationalize things to ourselves. And then this whole slew of decision biases, I'm not going to go through. I would suggest that anyone who's interested look into behavioral economics, because there's some really fabulous, fascinating things about how we as humans trick ourselves into making decisions that are not necessarily the best ones. We're actually quite good at fooling ourselves. So it's something to be aware of as you're going about both your personal and your professional life. So now a brief journey through professional ethics. The basis for a lot of these professional ethics, codes of ethics, are actually in the laws and regulations, whether it's constitutional or statutory law. Here I've identified some of the state laws that pertain to some of your professional roles. It could also be regulatory law that's been promulgated by agencies, or it can be common law based in the context of litigation and court rulings and interpreting existing law in new ways, or it could be executive orders. Now, codes of ethics are defined sets of principles that are developed and written and shared with people so that it helps them in making good decisions between right and wrong. And it can be used at all levels of society, for individuals, for professionals and organizations. And many are codified and others depend on how do you interpret it. So organizational codes are those that are defined by the organization to help those who work within that organization to follow certain guidelines of behavior. And it helps to provide procedures that can be used so that they can be fair and consistent about how they look at different issues that come up. Professional codes are often put out by the professional societies, such as you have, in helping to determine what's appropriate behaviors for that particular profession, and also helps to regulate the behaviors. Then if you think about it, most of us have unwritten, unrecognized personal codes of conduct, and it's heavily influenced by our background and our upbringing. But it is unique to each of us, although there's a lot of commonality within a certain society or culture. And societies tend to assume there are going to be certain behaviors, like basically you could say common decency, that guide our behaviors on a ongoing basis. Some select groups have codes of conduct that apply only to them, like the Japanese Yakuza gangsters. They have a code of conduct that they follow carefully, but it's probably not one that we would want to call our personal code of conduct. When you're talking about organizational codes of ethics, most of us work within organizations, and you should check with your organization to see if they have a developed written code of ethics. And if so, get access to it, take a look at it, and understand how it applies to the work that you do within your organization. That's one source of guidelines for behavior for yourself and your coworkers within that organization. If by chance your organization does not have a code of conduct or a code of ethics, the independent sector has a really good set of principles that can be adopted by organizations. There's also the National Council of Nonprofits has some really good examples, templates, and resources for developing a code of ethics for your organization. Or if you're a nonprofit and you use the IRS Form 990, that's actually a great walkthrough of things you need to think about. And SHRM, the Society of Human Resource Managers, also has a guide for developing a code of ethics. For professional codes of ethics, you can look at these websites at your leisure later on to find the codes of ethics that have been developed for social workers, dietitians, substance abuse counselors, and health educators. There might be others out there, and I'm sorry I didn't get a website for the nurses, but I didn't know you were also getting your CEUs today. But it's really important that you take a look at what are the professional codes of ethics for your particular profession, if they've been developed, and I think in most cases they have been. They usually cover similar ground, but the formats might be different. You should become familiar with them and how they apply to your own work. And as we go in the rest of the presentation today, I'd like you to think about how your professional code of ethics might apply or be impacted by the specific issues of dementia care. Now, most of these codes of ethics are relatively lengthy. They're several pages long, sometimes much longer than that. And so I can't go through each of them in great detail. Each of them would take more than an hour to walk through and sort of really dig into and explain or explore what it's all about. I just want to take a quick look at the social worker code of ethics and only certain portions of it. Here, the social worker code of ethics, the purpose of it is to identify the core values on which social work is based, to identify the ethical principles and specific standards that they're suggesting should guide practice in social work, to help identify the relevant considerations particular to social work that would arise on a common basis, to identify standards to hold people accountable to adhering to those standards, to help new practitioners to understand what it means to be a good social worker, and then also to be used to adjudicate complaints. So they identify some ethical standards, which are guidelines. Some are enforceable and some are just aspirational someday, or if we were all perfect human beings, we would act in this fashion. If it's enforceable, it would be according to the judgment of those who are looking at the alleged violations. So they identify the responsibilities that social workers have to clients, to colleagues, practice settings, professionals, the profession itself, and to broader society. And they go into depth in each of these areas. The Social Worker Code of Ethics is one of the best I've seen, and I really commend them on doing a really good job. When you look at the Code of Ethics in the section on responsibilities to clients, you can see there's 16 different items here that they've identified, and they talk about what to think about, how to consider things in these different areas in order to adhere to good, high standards of conduct for a social worker. The ones I've highlighted in blue are the ones that I think are most relevant to the issues of dementia care, namely self-determination, informed consent, what is competence, what is cultural competence and social diversity, and how do you help people who lack decision-making capacity. So that is the very superficial treatment of professional ethics that I can give you today. But as I said, I urge you to go online and find the professional codes of ethics that refer to your own profession, download it, read it, understand it, and see how it applies to the work that you do on a daily basis. So now we go into a little bit about how one makes ethical decisions, what you think about as you're struggling with a sticky situation or a problem that's nagging at you and is forcing you to stop in your tracks and say, wait a second, what's going on here? This is not just a routine decision. This has some sort of ethical component to it. It's that sort of gut feeling that, I better look at this more deeply and understand what the potential consequences are. So different sort of ways of looking at it, or sort of tools, are these 6, and I'll go through them briefly. First of all, you want to ask yourself, is there a legal component as well as an ethical component? Because as we recall, ethics and law are not the same, but in an ideal world, you want them to be compatible. You want to be following the law and following good ethical standards. So in the upper left corner, this is an easy situation. You're looking for how is it going to be compatible with both. In the lower right corner, it's actually pretty easy as well. If there's an option that's not legal and not ethical, then obviously you're going to walk away from that decision or that option. The 2 other quadrants are a little trickier. What if something is compatible with the law, but is not compatible with your ethical standards? How are you going to work through that? And even stickier than that, what about a situation where the ethics are telling you one thing, but the laws or the regulations are telling you something else? What if you still have to make a decision in that instance if you're not allowed to run away from making a decision? How do you make that decision? How do you approach it? And how do you implement it in a way that's going to be true to your ethics, but is not going to be breaking the law? Or if it does, which I'm not recommending, you do it with full awareness of the consequences, and you look for every possible other alternative. You become very creative to try and pull those 2 into compatibility as opposed to being at odds. So that's the first thing, ethical versus legal compatibility. Another interesting way to look at things is this really a problem that actually has a solution, and you have to work through things to understand what that solution is? There's actually a right or best answer? Or is it really a dilemma, a polarity, which is ongoing and actually unsolvable because of some interdependent opposites that are at odds with each other. So that if you were to focus on the one to the exclusion of the other, somehow you could end up in the territory of having negative unintended consequences. And one way to think about this is like breathing. Breathing is not just inhaling or exhaling, it's doing both. So examples of this are things like freedom versus security. If you go whole hog for security, what are you doing to damage freedoms? If you support freedom totally, what is possibly going on in terms of potential harms because security is not being looked at? Another example closer to home in the world of social and medical choices are autonomy on one side and caring and beneficence on the other side. If you go totally in the realm of autonomy, you're in the danger of abandoning people to their own autonomy. It's your choice. You just have to make up your mind. And even though we think this is the better thing for you, we're going to leave you to make your own choices because you're an autonomous person. Another example would be, again, individual versus community, justice versus mercy. So what this polarity map says is when you have a true dilemma like this, draw a map like this and put the two opposites at the left pole and the right pole, and then list, if you went all the way to one end, what's the upside of going totally for freedom, for example? What's the upside of going totally for security? And then ask yourself, if you went totally to one side for security, what's the potential downsides? So you look at the upsides as well as the downsides in order to understand what kind of trade-offs you might have to be making as you wrestle with this dilemma. Don't worry about not being able to see the small print. You can look at that later. The idea here is this is a basic framework, sort of focusing on the ethics part of things, a basic framework to work through a decision that has to be made. First of all, you have to recognize that it's an ethical issue. And then ask yourself, is this a choice between good and bad, or are you having to make trade-offs between two goods or two bads? Get the facts, what's known, what's not known, what else do I need to learn? Who are those who have stakes in the outcome, and what are their concerns? Have all the relevant people been considered? Have we looked at all the potential options? Have we been creative in finding options? Then when you evaluate your alternatives, in this instance, you're looking at, again, going back to those 6 ways of thinking about ethics: utilitarian, rights, justice, virtue, common good, and duty. Those are things you can think about, because if you remember, people are coming at what's right and good from those different points of view, not just your own point of view. So if you're a utilitarian, you still need to think about how somebody else coming at the same problem from a justice point of view or a virtue point of view is going to be looking at what's good and right versus just what you see as good and right from a utilitarian point of view. Then you make a decision and you test it, and you ask yourself which option best addresses this particular situation. And you ask yourself, if you were to explain this to your child or your spouse, or it suddenly showed up on the front page of the newspaper, can you explain that decision? Can you justify that decision? How do you say this is what we decided and why we decided, and be able to justify it? And then after you make the decision, how do you implement it and reflect on what did you learn in this particular situation that perhaps you can generalize to other things, or understand that this situation might be coming up again in the future. When you look at it from a code of ethics point of view, it's relatively similar. You're asking, what is the dilemma? What is the situation? What are the facts? You're again looking at ethical principles and approaches, just like that previous slide. But you're also looking, you have your professional code of ethics. What does it say? Does it address this particular instance? because it's relatively common in your profession? Or is it silent? Or does it make just general statements that say a good social worker will do such and such, and you go, yes, that's true, but that doesn't help me make a decision here. So you have to look at how well does your professional code guide your conduct, guide your decisions in this particular instance. Take whatever guidance you can and then augment it with some of these other approaches if you don't have enough specificity in your own professional code. Then again, you select the best alternative and you stand ready to explain it and justify it to other people. And then you look at how do you implement the decision, how do you evaluate what comes out of it, and how do you prevent or prepare for similar occurrences in the future. Now, if we're looking at it from a values framework, again, back to, whether they're personal values, professional or organizational values, again, the overall approach is similar, but there are some nuances and some interesting questions that this framework brings up. Whose decision is this? Who's going to make the decision? Who owns it? Who's affected by it? And do they support it? And if so, are they unanimous, or there's some dissenting voices? And have you thought about why they're dissenting and the value of what it is they're bringing up in that dissent? Why was the decision made? Try to understand what are the values, the particular values that guide the decision. Understand what are the most important ones, and ask yourself and be clear about why was this value the one that pushed the decision. And what I particularly like about this approach is it asks you to ask yourself, what don't you like about this decision? Are there negative consequences? Are you aware of them? Have you thought of them? Have you thought about who it's going to be affecting in a negative fashion? Who's going to bear the burden? Did you struggle with the decision, or was it relatively easy and straightforward? And if you struggled with it, what kind of trade-offs did you have to make between one value and another? And if for those values that did not rise to the top, why were they not given priority? It's really important to think about this, because then you're really understanding what those trade-offs are that you're making in this difficult decision that you're facing. And that's really valuable information. This Giving Voice to Values is a book written by Mary Gentile, or Gentile, I don't know the pronunciation. And she's basically talking about the things that you need to think about and sort of pre-digest and coach yourself on in order to do the right thing once you know the right thing. Again, sometimes it's hard to do the right thing even after you know what that thing, what is right. So moving on to, finally, ethics in dementia care. We're going to be looking at the specifics of the ethical issues to think about in dealing with people with dementia and their caregivers. The first thing to think about is that the traditional views don't always address adequately the concerns of dementia. Mainstream bioethics, mainstream health law has not been as helpful as it could be. And one point that's made is that ethics for dementia is not best served with moral abstractions, but really in listening to the concerns and the issues of those with dementia and their caregivers as they share their experiences. Dementia ethics, to continue this quote, can only be discovered in praxis or practicality and dialogue. It must be practical rather than deductive, abstract, and game-like. So if we think about the limits of the rational model, where am I? Sorry, I've lost myself here. Okay. The limits of the rational model. Since the Enlightenment, there's been a profound emphasis on rationality as the hallmark of human nature. The idea that the individual person is an isolated, rational, self-determining, self-identifying person, and that's actually not fully true, because as persons, we are far more than our rational intellect. We have feelings, emotions, tastes, desires, and yearnings. We are nurtured and in turn nurture in families and communities. And as dementia progresses, we come to depend more and more on others to help maintain our identity. The great burden and challenge for caregivers, families, and professionals is the work and loving care that preserves the identity of the person. We live in a culture that is the child of rationalism and capitalism, so clarity of mind and economic productivity determine the value of the human life. But the key to an adequate ethics of dementia is full attention to the many ways of enhancing the non-cognitive aspects of human well-being while not underestimating remaining capabilities. If you think about the rational model, turning a common experience of memory loss into a medicalized, labeled disease has many consequences. The current medical narrative is one that emphasizes plaques and tangles and a steady, inexorable degeneration of faculties. It focuses so heavily on loss that it is hard for patients, family, or professional caregivers to recognize the capacities that remain for human interaction. The medicalized care of doing to is easier, but often less called for than the basic interactional care of being with. Care includes joy, compassion, commitment, and respect. Care rejoices in the existence of the person with dementia. Care is loyal, even as the loved one fades from the sphere of familiar identity and becomes almost unknowing and therefore unknown, but still remembered. The acute care model has dominated medical ethics for the last how many decades. And one of the big criticisms of that is that the acute care model is not very helpful when you're talking about most of the journey of dementia. It focuses on the moment of crisis and on decision-making for intervention. Once the particular crisis is resolved, you revert back to more technical medical management. Some concerns in dementia are decisional in this sense, whether, for example, a person should continue to drive, or they can stay at home, or even live a little longer. But other concerns represent the fabric of our everyday lives: how to negotiate a bath with someone who may be fearful and confused, or what to do when an individual with dementia wanders. The focus on autonomy is also not always well suited to the world of dementia. Our popular conception of the independent, isolated, individual, autonomous agent fails to adequately take into consideration the social structure of caregiving that care plans depend upon and affect. Thus, the traditional bioethical frameworks are of limited assistance in thinking through such socially contextualized challenges. And then also, competency is something we tend to focus a lot in dealing with people with dementia. And what they're saying here is there tends to be a dichotomy: either a person is competent or incompetent. But in the real world, the real life of dementia, it's difficult to determine when that transition takes place and when the threshold is crossed. They say if we can move our thinking beyond the model of the isolated, autonomous individual as decision maker toward acknowledging the important social aspect of decision making, then the pressure to find a black and white label, competent or incompetent, diminishes markedly. This next section is an ethical framework that was suggested by the Newfield Council on Bioethics from the United Kingdom. When I was looking for information on ethics in dementia, I found the British literature to be much richer than the United States. Maybe we'll catch up, but they seem to put a lot more sort of integrated and cohesive thought into what it means to be ethically sensitive in dementia. So they came up with some policy recommendations in a framework of 6 items. And this first one just says basically the same as what we've been looking at in the past. You take a case-based approach to ethical decisions. You identify the facts, look at the appropriate values, and then compare to similar situations. But you still need to consider the unique aspects of this particular case. There is 2 other items is that they want to emphasize that dementia is in fact a brain disorder and that it is harmful and therefore not something to be overlooked or dismissed. However, with good care and support, people with dementia can in fact live well with their dementia. The 4th one is that in promoting autonomy for people with dementia, it's not just about rational choices, but making sure that you're supporting the relationships that surround that person and that you understand the values that underlie the decisions. And in promoting the well-being, don't just think about the objective factors of mental ability, but appreciate the value of the momentary experiences that people have of happiness and contentment in their life. And you need to promote the interests of both the person and their caregivers because they're a dyad that exists together and not in isolation. 5th is we need to act in solidarity with those with dementia and those dealing with it. We are fellow travelers on this journey. We don't know when we might end up in the same circumstances. We need to recognize our interdependence, and we have a duty to help people with dementia and their carers. We need to recognize that people with dementia are individuals, persons with equal value to those without dementia, and that they remain the same person even though changes in mood and behavior suggest that somehow part of them has slipped away. So implications for people with dementia and with caregivers. Again, they need to be respected as equal and valued individuals. They and their caregivers need support with the daily issues that they deal with. And to do that, they need a peer support and education, and that caregivers should be treated as partners in the situation. Implications for service providers. The approach that you use is more important than the format of the services. In other words, are you in fact, as you deliver the service, treating the person as a valued human being? Education and support are critical for the caregivers and the person with dementia. When you talk about timely diagnosis, when is the right time to pronounce the diagnosis of dementia for this particular person and family? It's not going to be cookie cutter, the same point for everybody. And in terms of providing services, what are the needs of this particular person, and can we meet those needs? Again, not a cookie cutter approach. For funders to understand that it is a medical disorder and it's not okay to look the other way until they reach a health crisis point. In our country in particular, there's a great problem with there being this chasm between health services and social services, and people with dementia need both, and they shouldn't be withheld because of a categorization of what kind of care it is. There's a big concern about how to fund these services, but the key issue is access to the right kinds of services. And for society, dementia needs to become normalized and accepted. We all have roles in dealing with the discrimination against those with dementia, not just those in the health and social service sectors, but everyday people in their everyday lives in society. And there's a need for more dementia-friendly buildings, communities, services all around everywhere that we go. Honolulu is has declared itself an age-friendly community, and additional steps need to be taken to make it not only age-friendly, but dementia-friendly. And finally, for research, there needs to be a better understanding of how research funds are allocated, not just to searching for cures, but looking for the best ways to support people with dementia and their caregivers in the reality of their lives. And they need to be able to make their own decisions about whether they will or will not participate in research. This last source that I'm going to reference is also British. As you see here, what they did was they did a meta-analysis of a huge number of journal papers that had to do with dementia that had some mention of ethical issues. And so they looked at over 500 articles. They finally did a deep dive in over 90 articles over a 12-year period, and they identified 56 ethical issues in 7 major categories. And so I would urge you to take a look at this document. I do have the reference in the references at the end. If you want to get a better understanding of these 56 issues in 7 categories and thinking about how it might apply to the work that you do. So here are the major categories of those ethical decisions, and I'm just going to do a very high-level sweep. When you talk about diagnosis and medical indications, there needs to be an understanding of the complexity of the diagnosis and when is the appropriate point in time to make the diagnosis. Reasonable treatment indications refers to the fact that there can often be an overestimation of the value of the pharmaceutical treatment options. It could be hype and hope as opposed to realistically what is that drug going to in fact do for that person. And if there's too much focus on drug treatments as opposed to supporting the daily life of people with dementia, then it needs to be looked at. And then again, adequate appreciation of the person as an individual. What are their existing preferences, and how do you honor their autonomy? When you're looking at patient competence, it's the fact that there is ambiguity in understanding what is competence, and there is, and in assessing competence, it can be an inadequate assessment or it can be done in a poor context. For example, time of day makes a difference in terms of a person is focused or not. The type of decision that's at hand. Is it a serious medical decision? Is it a from a medical point of view a trivial daily living decision, but for the person involved, the trivial daily decisions like, do I get to decide when I take a shower versus being forced to take a shower when it's convenient for the institution? That's a big deal for people, even though from the professional's point of view, it's like, what's the big deal? Well, these are the daily things that people live with and that affect their quality of life. In assessing authenticity, it's, are you making assumptions about what this person really wants? Just sort of being sort of cavalier about assuming so-and-so would want to make this autonomous decision? or do you really understand what is authentically desired by that person? And this issue of underestimating relatives' experiences and assessments is repeated multiple times, which means that there can be a tendency by professionals to undervalue what relatives and caregivers are saying and sharing about the person. Information disclosure, again, are you acknowledging issues of autonomy? Is the amount of information and the way the information is shared, is it appropriate to the needs of the person? Again, are the relatives being considered and heard, and are cultural aspects being appreciated? In terms of improving patient decision-making, there can be concerns about not involving them enough, not slowing down enough, rushing through decision-making, where these people, whether it's the patient or the family, just need more time to digest what's going on to be able to make a good decision. Understanding that relationships and continuity of relationships can be extremely important, and not infantilization, which takes away their ability or denies their ability to make decisions. With surrogate decision-making, it's a balancing act, because sometimes or often families may not actually know what the person wants. They never discussed it, so they don't know what the person would have wanted in this situation. So you can't always just assume that the family knows best. On the other hand, patients often have said, I want my family to decide for me. I trust them, they know who I am, so just listen to what they think is best for me. Advance directives and living wills. There's challenges in interpreting what those mean, particularly if those advance directives do not specifically address the issues related to dementia. Because in the later stages of dementia, the life and death decisions that are most prominent for people with dementia are clearly not the same as somebody with congestive heart failure or cancer. So if they have a very blanket advance directive, it may not give enough guidance as far as what the person would want given their advanced stage of dementia. Another thing to think about is that what they perhaps documented 10 years ago may or may not represent what they would want today, because preferences change over time as conditions and health conditions change. Again, going back to the carers around the patient, we want to do what's right for the patient, but we have to understand the very heavy physical, psychological, emotional burden on those who are caring for the dementia patient, the relatives, and even the professional carers. We also have to consider, is there potential harm to others? And also, what is responsibility in terms of costs and limited resources? For example, neuroimaging can be very expensive. How useful is it going to be in actually making a difference in treatment or outcome? Is it the right expenditure to make in order to provide the best care for the individual? And then in terms of the actual care process, an issue is always keeping in mind both benefits and harms and what those potentially can be. Again, making sure that the patients are empowered to the best that they are able to exercise at that point in time. And for carers to think about themselves and their own attitudes towards people with dementia, to understand their own values that might be at play, and to continually look at educating them and building their capacity so that they can better serve people with dementia. And then in terms of abuse and neglect, let's see. it raises particular ethical issues because of those complex and deep relationships and dependencies that build between the patient and the carer. Frustration and fatigue can lead to people acting in ways that they would not otherwise do. And so it's really trying to help both the patient and the carer to move beyond issues of abuse and neglect to the right thing. Some of the special situations that they describe as ethical issues in this article are listed here. And I just want to focus on those last three: tube feeding, end of life, and suicide thoughts. In particular, for those who are in dietetics and nutrition, this is a key issue in dementia care, that towards the end, as people are less able to feed themselves, there's the question of whether you're going to put them on artificial nutrition and hydration. And there's not evidence that will actually necessarily achieve the desired goals. The question shouldn't be, do we PEG or not? But what is the preference of the patient, and what is most important for the patient and their concept of a good life, so that they're getting the right treatment at that time. And it may or may not be artificial nutrition and hydration. In terms of end of life and palliative care, there's evidence that people with dementia experience poor care, badly controlled pain, and have little control over the manner or place of their death, and there's significant stress on their caregivers. For those who are hospitalized, those with dementia seem to be less likely to receive palliative referrals, medication, and less likely to have attention paid to their spiritual needs. So that's something to keep in mind, that people with dementia can be particularly vulnerable to not getting what they need at the end of life. And then in terms of suicide, I'll just read the quote. Studies show that many individuals with dementia enjoy human interaction, physical and mental activity, and other aspects of living, even as the disease progresses. Thus, the comment, I, the doctor, hear from many cognitively intact adults, I wouldn't want to live that way, does not seem to be true for the majority of people who develop dementia. So not projecting our beliefs and our views onto the person with dementia in terms of, is this the quality of life that they would want to continue or not, is a big moral question that we have. So I have come to the end of my long ramble. We do have time for questions. And as I said, you can always email me later, either to get a copy of the presentation or to ask any follow-up questions that you want, and I will be happy to respond to your emails. So, do we have questions?
Not right now. Maybe. If anyone wants to ask questions, please feel free to write them in the chat. We have that here, and we're available for any questions. That was awesome. Thank you. Yeah.
Do you have any questions?
Oh, hi. Here's one. Related to guardianship cases, competency versus capacity, are these terms same or different? If they are different, how are they different?
Competency and capacity. The capacity is the capacity to make decisions. Competency is, are you competent to make decisions? They both relate to decision-making ability. So I don't know if legally they're the same, but from the point of view of asking, can you ask this person to make their own decisions? To me, they're the same. When it comes to guardianship, This goes to the question of what kinds of decisions are you asking the person to make? If they're not competent to, on a, on a reliable basis to make financial decisions, that, or to make healthcare decisions, those are different from decisions of daily life. So a person might be assigned guardianship because they're no longer able to make legal decisions or financial decisions. And so they're assigned guardianship. But even if they no longer meet the test for making those sorts of decisions, we should not assume that they cannot and should not make all the other decisions related to their life that affect how they live and what is the quality of the life that they live. And I think that that's the issue that sometimes gets confused, because people think, well, if they can no longer make these legal or financial decisions, then we have to decide everything for them. And that's certainly not the case. I don't know if I answered your question adequately, but I'm sorry, that's the best I could do at this time.
In this context, is there a significant difference between mild cognitive impairment and dementia?
Yes, there is. Mild cognitive impairment is pre-dementia. It means there's some diminishment of capacity, but not to the point where it's diagnosed as full-fledged dementia. It's basically the level of severity. Something to keep in mind is that whether it's mild cognitive or impairment or dementia, it's extremely important to try and get a diagnosis and to rule out other potential causes of these issues. For example, there are certain medical conditions that can cause brain fog, basically. You know, you sort of lose your acuity, lose your memory, not because you have ongoing progressive dementia, but because you're on certain drugs that are impairing your ability to think or remember. There's vitamin deficiencies that can cause that. There are health conditions that can cause that. So there are a number of things that could actually be reversible, so that the person can regain their cognitive abilities. So as you move into that stage of mild cognitive impairment and into dementia, let's make sure that we're ruling out any temporary conditions that can be treated.
Another question was, how are guardians and POAs determined?
Well, power of attorney is, I believe, something that would have been identified and agreed to by the person before they lost their cognitive ability. So it's one of the most critical things, I think, is that dementia be diagnosed, or, you know, mild cognitive impairment with potential dementia down the road be diagnosed early on, so the person can start putting into place those documents and documenting their decisions and their preferences while they are still cognitively intact. So, you know, filling out an advance directive with specifics about what their treatment preferences are at the end of life. For example, with dementia, the loss of the ability to eat is often one of the things that it often is occurring at the end of life. And so giving them the opportunity to say up front, when I reach that stage, I do or don't want artificial nutrition or hydration. You know, I do or don't want antibiotic treatment for, you know, a pneumonia or other infections. You know, let me go, or no, do everything possible to keep me going. Back to the POA, again, that's something that while they're cognitively intact, they can say, I want so-and-so to be the one to be the primary decision maker for my care. If they don't have those in place, they don't have any indication of what their wishes are. And if there isn't a clear identification of somebody who will step in, then the question is, well, now that they can't express their own desires, who does make those decisions? Who in the family makes those decisions? It might be a neighbor, it might be a lifelong friend, and not somebody in the family. If somebody has nobody designated, then the question is, there's nobody immediately evident to make those decisions, so who does it for them? Then you have to go through guardianship, which is a complex and expensive process, and this is something that hospitals often have to deal with. If somebody ends up in the hospital and there isn't any clear decision maker available to make decisions for them, and they can no longer make them for themselves, the hospitals are stuck. Who do we turn to make those decisions? It's expensive for the hospitals to then go through the process of getting a guardian appointed so that somebody has the legal right and the legal responsibility to decide for them. That's why it's really important for people to do that up front while they still have their clear mind, and not leave it to chance or other people's decisions.
This is another one. I have found that PCPs are shying away from declaring competency and having carriers have competency determined by psychiatrists. Are you finding this to be the norm?
What seems to be happening is that a number of physicians are reluctant to pronounce the D word, dementia, for a number of reasons. They don't want to stigmatize the person. They might be concerned, okay, well, if I say this person, my patient has dementia, maybe they'll lose their license. They won't be able to drive. You're taking away whatever freedoms they still have. So there's often a reluctance to make that diagnosis. And what commonly can happen is, without telling the patient they have what appears to be dementia or onset of dementia, they'll prescribe a medication that's for dementia, but they won't tell them what it's for. Here, take this medication, it'll help your memory. But they don't say, you have progressive dementia. So the person goes about their life not knowing they have dementia, not knowing that the road that they're on going forward is fraught with all sorts of conditions that, gee, wouldn't it be nice if they planned up front how they wanted to navigate that road? And that road can be a few years long, it can be 20 years long. So again, giving them the opportunity, even if it's difficult to give the bad news of, I'm sorry you have dementia, or you appear to be on the road to dementia, it gives people the opportunity to prepare ahead for what their life will be going forward, instead of shielding them from it. And yes, PCPs probably would not be the ones to pronounce on competency per se. They can be looking at possible diagnosis of dementia, but competency per se would be something that somebody else would be dealing with, because it has those legal ramifications.
There's another, went through training on ACEs or childhood trauma associated with the evolution of the disease. Is this an area of concern, do you think?
I do not know what this is in reference to. ACEs. I do not know. They'll have to explain their question a little better.
I think it's adverse childhood experience. That's why it says, or childhood trauma.
Adverse childhood experiences.
I'm sorry, I can't answer that one. I don't know how to answer that.
I've seen it many times where someone with dementia has an advanced healthcare directive that is very clear about something and the family disagrees with it. They put a lot of pressure on the doctor to do as they say and not as the person directed. I've seen doctors defer to families, and I've seen doctors hold firm to the directive. What do you think about situations like this?
An advance directive identifies what your preferences are. In an ideal world, the doctor and your family will honor your preferences. However, what can often be the case is all the family, or maybe one member of the family, has a different point of view. And if they really push on that point of view, they can essentially override the advance directive. And that's not to say that that's the right thing to have happen. But if the patient is lying there unable to speak for themselves, and someone is a very vocal proponent of a certain course of action, it becomes more difficult to say no to that person, particularly if they start sort of hinting at taking legal action and things like that. Mm-hmm. Hospitals are getting more comfortable with sticking with what the advance directive says. I've noticed over the past 10 years or so that hospitals are more willing to take the legal risk of potentially going to court by saying, we're going to follow the directive because that's what it says. But what they'll usually try to do is try to continue to work with the family, to go beyond the conflict, to keep working with the family, to get them to understand the point of view that the patient had expressed and what they believe is the clinically the right thing to do, and to negotiate with them. It doesn't always work, but a lot of times they're really reluctant to push it to the limit. So they will often, or sometimes, cave to a vocal family member.
Okay, we have two more questions. How much authority does a temporary guardianship, who is also the wife, have over the person who has consistently wished to go against his wife's discharge plan?
I cannot answer that. That sounds more like a legal question than an ethical question. From an ethical point of view, you would want the person, the patient who I clearly indicated what their preferences were, you would want that person to be heard and heeded. When push comes to shove, again, it's, are they willing to take it to court? You would want their wishes to be heeded. That's the whole purpose of having an advance directive. But when push comes to shove, that's a different matter. I'm sorry to say.
Okay, do you know of any resources to assist families, carriers, who are trying with limited success to assist patients with dementia who are in danger of self-neglect due to not wanting assistance from others, due to paranoia, agitation, etc.?
Self-neglect is, it's a serious question. This gets at one of the really deep ethical issues of aging and dementia. How far can concerned carers, concerned family members push somebody to do what they don't want to do, even though you know it's in their best interest? This is a delicate balancing of autonomy and doing what's right for the person. And I don't think that there are any readily available resources if there's a case manager who has a good, or a social worker who has a good trusting relationship with the patient, that might be helpful. From what I've read in the literature, it's developing a relationship and developing a sense of trust between the patient and the person trying to help them. That's the most important thing. It's not a quick fix. It's not something you can go in and just take care of. It could take a long period of time of developing that relationship and developing that trust before the person may be willing to act differently and act in a way that's better for them. It's a very sticky situation. But again, the time element, the trust element, the relationship, and not just sort of bulldozing your way in, I think has been found to be the critical factor.
Okay, final question. I'm understanding that the word dementia is replaced with neurocognitive disorders in DSM-5 because of its social stigma. Are we still able to use the term as healthcare professionals?
I don't know the answer to that. Neurocognitive disorders is a mouthful, and most people don't understand what you're saying when you say that. In my world, using a simpler word like dementia is better. Another thing to keep in mind is people often talk about Alzheimer's disease, and that is the most common form of dementia, but there are many other forms of dementia. So dementia is the umbrella word. And I'm all for using shorter, fewer words, but I don't know what's quote unquote acceptable and politically correct. So.
Okay, well, thank you for joining us, folks. That's all we have today. I will upload this video on our YouTube channel following this presentation, and I will also be sending out the evaluation survey link. Thank you, thank you, Linda.
Thank you.
Everyone have a great rest of your day.
Thank you.